neoplasms in childhood and adulthood may be different in kind of the tumor. You see a table, common malignant neoplasm in infancy and childhood is listed according to different ages, from first to 4 years of age, 5 to 9 years of age, and 10 to 40 years. You'll see at the top of the list of all of them is leukemia. And hematopoietic systems are the most important malignancy in all ages of the childhood period. And hematopoietic system and neural tissue and soft tissues are the most common malignancies in the childhood. But epithelial tumors in adulthood is the most common malignant tumors, the opposite of the childhood. Okay, and we talk about some of malignant tumors, including neuroblastoma, retinoblastoma, and Wilms tumor, malignancies of the child. Okay. Neuroblastoma is the second most common solid malignancy of childhood after brain tumor. Accounting for 7 to 10% of all pediatric neoplasms, 50% of malignancies diagnosed in infancy are neuroblastomas, and most of them occur sporadically, yet 1 to 2% of them are familial and inherited in autosomal dominant manner, but most of them are sporadically. Neuroblastoma. Neuroblastoma originates from sympathetic ganglia or from adrenal medulla. Both of them originate or derive from primordial neural crest cell, according to your embryology. You read in embryology lesson that's saying to you about it. Primordial neural crest cells are subdivided into sympathetic ganglia and medulla of the adrenal. Both of them are originate from neural crest cells. So, malignant process in both of them have the same manner. Olive gene or anaplastic lymphoma kinase gene is involved in neuroblastoma. If this gene have germ-line mutations, so we have the familial forms of neuroblastoma. But in somatic mutations, in 8 to 10% of the sporadic ones, it may be markers of adverse prognosis. Olive mutation is one of the markers of adverse prognosis. And in clinical trials, there used some inhibitors that target the mutated olive gene, tyrosine kinase, are underway to be influenced for treatment of the neuroblastoma. Again, these frames, I said, the frames that are labeled by morphology in the Robbins Pathology book are really important. They are including many important data for glass examination and a microscopic examination. You see in the morphology frame of the neuroblastoma some data. This frame say that 40% of neuroblastomas arise in the adrenal medulla, but anywhere like the sympathetic chain may be present in paravertebral area with different percentages, posterior mediastinum, and they have many different sides, and they have many different features in gross examinations. Some of them are sharply demarcated, but some another one may be infiltrated and invade to the surrounding structures or surrounding tissue. In cross sections, they may have soft consistency, great in appearance, and brain-like tissue may be present. Some areas of necrosis, cystic degeneration, or hemolytic area may be present. You see in this picture a gross feature of the neuroblastoma in the adrenal tissue. In the microscopic investigation, you see some features. Some tumors that are derived or arise from undifferentiated tumors, undifferentiated cells that their origin is not definitely clear. Some tumors such as neuroblastoma form some rosette-like structures, flower-like structures. If these tumor cells arranged in flower-like structure, so-called rosettes, rosettes formation. It means flower-like structure. Sometimes tumoral cells arranged such a flower-like structure around an empty lumen. And that's a structure so-called rosettes. But if the tumoral cells arranged around a vascular structure or blood vessel, vascular structure or blood vessel. Okay, it means that's a structure so-called pseudo rosettes. It's not a true rosette. Okay? And if the tumoral cells form flower-like structure with rosette, but in the center of them there is no empty lumen. If there was some cytoplasmic process, there's a structure also known as pseudorosette. Only when the empty lumen is at the center, the term rosette is used. Okay? In neuroblastoma, The tumor cells arranged around. Okay. You see some tumoral cells in neuroblastoma in this picture that are arranged in flower-like picture, okay? And at the center of them there is no empty node, okay? So it's a pseudo rosette. Understand?
Yes.
So it's a pseudo rosette because at the center of them there is no any empty node. The special name of the pseudo rosette that's seen in neuroblastoma is Pomeroy's pseudo rosettes. You see Pomeroy's pseudo rosettes in the neuroblastoma. It's a histological clue of neuroblastoma. That's enough for you. Classical neuroblastoma composed of small primitive appearing cells with dark nuclei, scant cytoplasm, high density ratio, poorly defined cell borders, and solid sheets. And you see some mitotic figures, choreorexia that are due to nuclear breakdown, and polymorphism may be prominent. The Homeroid pseudo-rosette structures are the histologic clue of the neuroblastoma. These are tumoral cells of the neuroblastoma with high density ratio, scant cytoplasm. There is some mitotic figures and brief mitotic activity really is present. If in addition to the Homeroid pseudo-rosette structure in neuroblastoma, you see ganglion cells, the nomenclature of the tumor is shift to the ganglioneuroblastoma. Ganglioneuroblastoma means that in addition to presence of these features, Homeroid pseudo-rosettes and undifferentiated sheets of undifferentiated tumor cell, you see some ganglion cells. Ganglion cells are mature neural cells. If they are also present in addition to the undifferentiated tumor cells, you use the term of ganglioneuroblastoma for the tumor. Okay?
Okay.
These slides show for you schematic features of the rosette structure. Empty lumen, so it's a true rosette. At the center of the tumoral cells, you see some cytoplasmic process. So it's a pseudo-rosette. Pseudo-rosette of Homeroid pseudo-rosette that is evident in neuroblastoma. That is a histologic clue of neuroblastoma. Then there are some other types of rosettes, perivascular pseudo-rosettes. These type of pseudo-rosette structures are present in ependymoma, or in retinoblastoma you see such rosettes. Flexner-Wittgensteiner rosette is a specific name for the type of rosette that is seen in retinoblastoma. Okay. About clinical course and prognosis of neuroblastoma, some factors should be noted, should be mentioned. The staging of neuroblastoma. Unfortunately, most of the children that are involved by neuroblastoma present in stage 3 or 4 of in stage 3 or 4 tumor, and so they younger than 18 months is much more favorable prognosis. And a stage of stage 1 or 2 or a stage 1 or 2 have a better prognosis than the higher stage. Histology feature also could be we have prognostic role. An independent prognostic variable is histology feature. If you see gangliositic differentiation or Schwann stroma is indicative of a favorable prognosis. Schwann stroma and presence of gangliositic differentiation means that differentiation is happen in the best situation, but so if differentiation was better, so prognosis also would be better. Schwann stroma and gangliositic differentiation is indicative of a favorable prognosis. You should know this point is very important. Some oncogenes such as MYC-N oncogen in neuroblastoma is amplified. So presence of MYC-N oncogen amplification would be associated with worse prognosis. The greater the number of copies, the worse the prognosis. Okay? DNA poloidy and also mutation in RAS-MAP kinase pathway, all of them have worse prognosis, but mutation in RAS kinase pathway is related to relapsed neuroblastoma cases. Children younger than 2 years show abdominal mass, fever, weight loss, and in the older children, unnoticed may remain unnoticed until metastasis. There's hepatomegaly, ascites, and bone pain, they may be present. And metastases may be present in hematogenous manner or lymphatic manner, particularly to liver, lung, bones, and other organs. This slide shows you skin metastasis or cutaneous metastasis and infant with neuroblastoma. This feature is visible very often. They say that because of the resemblance of these cakes, they are called as blueberry muffin babies because of multiple cutaneous metastases that associated with deep blue discoloration to the skin. Disseminated neuroblastoma. It's really resembled to this case. 90% of neuroblastomas they have elevated blood level of catecholamines, but they can be used for screening, but despite the elaboration of catecholamines, hypertension is not present in these patients. Okay, about neuroblastoma, the most key feature that you should know is that in neuroblastoma, key feature about neuroblastoma. And about retinoblastoma. Um, Retinoblastoma is most common primary intraocular malignancy of the children. 40% of common germline mutation in RB gene or retinoblastoma gene. That these one are inherited and maybe bilateral, and maybe unifocal or unilateral, but some of them are somatic mutation in RB gene. About 60% of them that involve in sporadic manner. But those ones that have germline mutation in RB gene, they have an increased risk of the development of osteosarcoma and other soft tissue sarcomas. But these one in somatic manner, somatic mutations in a sporadic manner, they didn't have association with increased risk of osteosarcoma. All of the somatic RB mutations or sporadic retinoblastomas, all of them are unilateral and unifocal. A healthy eye compared to retinoblastoma. In the retina, you see a mass, so-called retinoblastoma. And this one is cut sections of an eye that is involved by retinoblastoma. You see the tumor is filled all the space of the eye. Clinical features are poor vision, strabismus, whitish hue to the pupil, and that's called cat's eye reflex. In a normal eye, you use the ophthalmoscope to examine the retina of that. In front you see a red reflex in a normal eye. But in these eyes you see a white reflex in the ophthalmoscopic examination. They have pain and tenderness in their eye, and the median age is 20 years and also may be present at birth. Okay, another morphology frame, and this one about retinoblastoma. Retinoblastoma makes some nodular masses in posterior retina, and also satellite settings around it. And this tumor also is composed of some undifferentiated tumor cells with high answer ratio. Some of them arranged, some flower-like structures, but in retinoblastoma you see flexular Steiner rosettes. These structures has some difference between another one. Flexular Steiner rosettes in retinoblastoma. So the rosettes, okay. And this one is like this. And so the rosette of the neuroblastoma picture. Right? sign the cytoplasmic process, and both of them there is no empty lumen. Empty lumen is this one, and this one, and this one. All of them are flower-like structures that they haven't empty lumen. So you see in this picture, Flexner and Steiner pseudorosette versus Homerite pseudorosette. In the Homerite pseudorosette, the lumen is filled by cytoplasmic process, but in Flexner and Steiner, there are some cytoplasmic process that don't fill all of the center of the lumen. Okay? If retinoblastoma would be untreated, the tumors usually are fatal. And when treated with chemotherapy or radiotherapy, survival is the rule. So if retinoblastoma is diagnosed at the suitable time, it would be cured. Some tumors also spontaneous in retinoblastoma. Okay? Is it any question? Okay?
Bye.
And the last title, Wilms tumor. You have a little background about Wilms tumor because I explained to you in practical session yesterday. Wilms tumor or nephroblastoma is the most common primary tumor of the kidney in children. Median age is 2 and between 2 and 5 years of age. This tumor is associated with abnormality in the gene of WT1, WT2, or Wilms tumor. WT means Wilms tumor. Wilms tumor 1 and Wilms tumor 2, they are located in 11 chromosome in different locations. In a short part of the chromosome, 11 chromosome, in location 15, you see WT2 gene, and in location 13, you see WT1 gene. Okay, if each one of them was being mutated, the Wilms tumor may be present. Wilms tumor and the infants. Normal kidney histology is in this picture, glomeruli and tubules, renal tubules. Again, morphology frames, full of data. And that's what about Wilms tumor. Wilms tumor are large, solitary, well circumscribed. They are soft in consistency, hemorrhagic, and tan to gray. Foci of hemorrhage or cystic degeneration and necrotic area may be present. They have three-phasic combination of the blastomal component, the stromal component, and epithelial component. I said you yesterday about it. In blastomal component, you see sheets of small blue cells with high answer ratio and few distinctive features. But in epithelial cell types, you see abortive tubules or glomeruli, and in the stromal component, you have a fibrocystic or myxoid in nature, and for example, maybe skeletal muscle differentiation would be present. Mutation of TP53, TP53 mutation may be present, and these one show aneuploidia. About 5% of the tumors may show aneuploidia and have TP53 mutations. They have resistance to chemotherapy, unfortunately, and in this slide you see those tumor components, blastomal components, sheets of a small round cell, this one, and epithelial component includes abortive granuli and tumult, and mesenchymal component in the stroma, you see fibroblastic features. These areas are blastomal components. These one are epithelial component, and the paler area are the stromal or mesenchymal components. So stromal component, the spindle cell appearance, blastomal component, and epithelial components. 3 components are those tumor. You see pictures of aneuploidia, atypia, and brisk mitotic activity with atypical forms of mitosis. If these features are present, that is present in about 5% of those tumors, it is associated with poor prognosis. Some syndromes, such as Barber syndrome, Dennis-Drash syndrome, and Beckwith-Wakeman syndromes, are in the childhood that may be associated with Wilms tumor. In Barber syndrome, Wilms tumor is present, associated with aniridia, genital abnormalities, and maternal retardation. The gene that is involved, darolutabon. And Dennis-Drash syndrome have darolutabon mutations also, but Beckwith-Wakeman syndrome have mutation of darolutab2. All of them have are associated with Wilms tumor. Sporadic forms of Wilms tumor are in 90% of cases in children, and beta-catenin gene also may have some mutations in the Wilms tumor. TP53 mutations are associated with poor prognosis. And about their clinical course, you have colloidal abdominal mass access across the midline and down into the pelvis, fever, abdominal pain, hematuria may be present. Their prognosis generally is very good and excellent results after nephrectomy and chemotherapy is evident. But presence of aneuploidia is a harbinger of adverse prognosis, but only if it is diffuse. It's an important point. If aneuploidia is diffuse, would be associated with adverse prognosis, but focal aneuploidia is not associated with poor prognosis. Diffuse aneuploidia is important. Okay. Does anyone know what I know? It's a poem at the end of the class. Maulana. I read it for you at first in Persian, and that after that in English. تو معلوم همه به جنگت روز صلح من چه آید تو یکی نی هزاری تو چراغ خود برفروز که یکی چراغ روشن ز هزار مرده بهتر که به هست یک قد خوش ز هزار قامت خوش. In English, do you know this
very
I read it, yeah, I read it in English for you. تو نگو همه به جنگند و ز صلح منشه آید. Never say in a world full of war, of what use is mine peace. You are not one, you are 1,000. Light your own lamp. And for one lit lamp is better than 1,000 lightless ones. One upright stature is better than 1,000 hunched backs. Okay? Just try to be the best one of yourself and try you be the best one in your field and just do it without any other attention to the others and focus on your work. Try and be success.
Thank you.